and maybe it's rumour or actual fact, I don't know, but the design of the building itself, any truth that the design, the ducting or the corridors for cabling and for toilet piping and all that is too small. It's not designed wide enough, and you heard this rumour now, and it's not designed wide enough to carry all the necessary facilities going through these corridors. If you want to call them corridors or ducts, or whatever you like to call them, ducting, to carry the electricity set through toilet pipes, all that they're not wide enough and big enough to take them, and that is causing a problem. And then the second one I want to ask you in, were they steel beams or something, I don't know what kind of structures they were, ordered in from abroad, and when they came in they were too big to fit, and they had to be cut to adapted to fit in at a severe cost. Is there any truth in any of those rumours?
On the first question, we are not aware of any corridors not being large enough to cater for the designed M&E services as set out in the GMP. And just to say on that, we have brought the design of this building to a very, very high level in terms of BIM information modelling. So we have a 3D of every single service in the building, and that was done for GMP. So we were very confident that all of the services fitted within the corridors. And I can also confirm that I'm not aware of any claim that's come in to say that the services are not fitting in the corridors. So that's the first question. And the second question, I'm not aware of any steelwork that came in that had to be cut or altered. And that if such thing should happen, it would be the contractor's responsibility and not the employer's.
The reason why I'm asking, because we have a little bit of ructions here last week over a printer that was bought here that wouldn't fit into. I just was told this, that the same thing could have happened in the Children's Hospital, the building of the Children's Hospital. So I just want I'm clarifying that this has happened. Actually, who are the design team? Were they Irish or the foreign design team that designed the whole building? Just as a matter of interest, someone asked this.
So we have a mixture. The lead architect is BDP. They're a UK firm, but their partner is an Irish firm called O'Connell Architects. They're indigenous. The quantity surveyors are Lineside, who are an indigenous Irish firm, but they're also global. The M&E design engineer are Arab. They are a global firm again, but they've been established in Ireland since 1946. So they're with 500 people, so they're an Irish firm, you could say. And then O'Connor Sutton Cronin are the civil and structural engineers, and they're an indigenous Irish firm.
And if there were something like I spoke about, who would carry the can? Would BAM or the contractor, the design team, or who the contractors are, or the design team carry the costs if there were something wrong like that on the design? Who would carry the responsibility and who would carry the costs if there were something wrong, like fitness?
Well, if you take the steelwork, if the steelwork came into site and it was the wrong length or something like that's generally a contractor's responsibility.
Okay, BAM in this case, isn't it?
Or the subcontractor.
Or the subcontractors. And the design, if there was anything wrong with the design of the building, who would take responsibility?
If the design of the steelwork was incorrect and it had to be changed, that would be an employer responsibility through the design team.
The taxpayer wouldn't be caught for any of the costs?
If the design of the steel beam was incorrect and it was a design team mistake, the taxpayer would be responsible, the employer would be.
That's why I'm asking, because it could fall back to the taxman again.
Yeah. Okay, I think.
Thank you, Chairman. I just want to welcome Mr. Reid and his staff here. I'm just going to start on the Controller Another General's report. It's nearly identical to the report he also had in 2010 and 2001. And, it's recommending, we all know about primary care, what the ambition of primary care is to keep people out of hospitals and to keep as many people at home and looked after and treated as near as possible to their own homes without blocking up the system in beds in hospitals, etc., and the trolley situation that we have at the moment. But I want to ask you first and foremost, 2001 and all governments down to the years have all placed great emphasis on primary care and in all their manifestos and the HSE themselves. But we don't seem to be making great progress. It seems to be at a standstill. 2001, that's 20 years on we are now, and we're only at a third of the targets that were set in 2001. So I want to ask first and foremost, why is it taking so long to roll out primary care? And 20 years we should have the targets were set should at least be more than 30, a third of the percentage of the ones that we had earmarked in 2001. Can you answer that first?
Thanks, Chair, and thanks, Deputy. Just to say, firstly, I do agree with your summary opening piece just around the value of primary care centres and dealing with our patients and the public in a primary care setting. The ones that we do have and operational, there's no doubt where we have a GP presence in place. It provides a significant extra service to the community and provides specific relief to our acute settings, particularly our emergency departments. Directionally, in my view, the dislodge care direction is absolutely the way we want to go. We have a lot of primary care centres, even existing, that don't have the diagnostic capability that would really enhance the supports they can give the community.
Can I ask you to stop you there? Why haven't they? Right, what's the reason why they haven't them? You know, I just want to know as you go along, explain why they haven't their diagnostics.
I think it's been, in the past, it's been an investment priority, which has been to invest in the current demands that we have on our service, where the pressure points currently all head towards our emergency department and our hospital acute settings. The shift that we really have to make, and in my 6 months since I've been here, I'm absolutely convinced, we have to reduce the numbers of presentations that arrive, not through anybody's fault, but that arrive to our direct emergency departments. That has to be done through a number of ways, and the dislodge care does set out a kind of strategy for this. It has to be done by, we do need more GPs. I've been talking with the training body for GPs. Bringing more GPs on stream will be key for us. We do need to enhance the capacity and capability of our pharmacies in terms of the reach that they have into the communities. So reducing the numbers of people who need to present to emergency. We can only do that by strengthening our primary care teams. Very positively, I have to say, in our service plan, which is just being finalised, I'm at government with the Minister to go to government shortly, you will see an enhanced investment for next year in our complete primary care settings. So from a number of perspectives. Firstly, enhanced investment in terms of nursing home support schemes, enhanced investment in home help hours, but particularly the capacity now to increase our resourcing in the community settings, primary nursing, etc., by over 1,000 by the end of 2020. So there's a €10 million investment. So to specifically answer your question, we need to shift the investment profile from traditionally into the acute setting, which is under pressure, and make a shift primarily into primary care settings while supporting acute settings.
If they are a fail in the system then that's been rolled out, we said the last 20 years, can you identify how we can rectify that? Is it money? Is it GPs are not interested in rolling it out? Is it the structures? Is it grant aid? What's the main failing of it not being rolled out in those 20 years? You know, what is the reason why it's not being taken up more, being rolled? We know the ones that are in, we have them in my constituency in Kilkenny and they're working brilliantly, the ones that are there. And there's plans for more, but they've been spoken about 10 years and they're still not up and running. Why is that not happening? What is the reason for not being rolled out faster?
Well, just say, I mean, factually, it's in the CNAG report and indeed our own report. There are 127, and there's another 170. Sorry, there's another 77 coming on stream. 30 of them are in our capital plan over next year. And if you take the 77 still to come on stream. 10 will be from our corporate plan next year, and 67 of those will be from primary care operational leases. So a significant number will come on stream over the next 3 years. To go back to the original point, it's not just about building a primary care centre. It's about equipping the centre with the facilities that can enhance the patient and the public experience in them. I hear your reference to your own experience. It varies across the country. We don't have our primary care centres with the capacity that they need. We don't have sufficient GPs coming on stream. That's getting better. So, you know, I'm agreeing with you. We have to make that capacity strengthened in all of our primary care centres. Diagnostics, GP, therapist skills, so people aren't, you know, having outpatients appointments in the acute setting. So it's an investment shift that's required to strengthen our community setting.
Can I ask just of the 127 that are up and running? I know you mightn't have this at the top of your head. Where are they mainly? Are they well spread around the country? Are they focused on kind of Dublins and cities? Or are they well spread? Are the areas, we say in other words, are the areas very neglected for primary care?
No,
counties
we have a very good spread, Deputy, and I'm happy to provide the full spreadsheet, which will give you the locations. supplied to the committee of all the locations.
It's actually an Annex 15C of the report actually lists all of the locations by CHO and the status as at March of 2019.
Are they well spread geographically?
They are spread around.
Spread
yeah.
geographically. Okay, I want to move on into next. Do you know the different ways you can go and roll out primary care, lease agreement, public-private partnerships, PPPs or HCs, direct build. I just want to ask, which of these is the most prominent, or which is the best system, lease agreement, PPPs or HC direct build? Which of them is the most effective, and which is the best to go forward to get the other two-thirds that we're looking for up and running? Which is the most cost-effective? Which is the best value for money?
Yeah, well, you know the three methods that we have. So firstly, we will do a new review. There was a review, as the CNIG has recommended. There was a review done in 2008, and that concluded by the three methods that the operational lease was the most cost-effective in terms of cost-benefit analysis. But we do want to review that now again, based on our experience with both PPPs and. Can
you explain each one of them as you go along, just which is the best, why is the lease agreement? I mean, I presume just lease a building. The public PPPs, I understand, someone comes in private partnership and they produce an HSE, of course, your own direct build that you build yourself. I just want to explain each one and which is the most cost effective as you go along.
Yeah, I just asked my colleague Dean and Jim Curran to comment, but just to say, the three different methods are about first-time situation, which one works best. So, for example, if it's our own premises and we're enhancing our own premises on our own land and existing premises, it's absolutely calls out for a capital plan investment that we should do. There's other levels where you're trying to reduce and mitigate the risk and share the risk in a PPP environment, which is what we do. And then from a cost-effectiveness perspective, operational leases where they arise and the opportunity is there. But we don't always have the choice in terms of these three choices presenting themselves in terms of people ready for leases or people want to working on PPPs with us. But I might just ask Dean Sullivan
So each of the three models has strengths and weaknesses. Each of the three models is appropriate for different circumstances. PPP, it's obviously dependent on a government policy.
Which is best for the taxpayer?
Well, in terms of, as Paul has said, in terms of the 2008 review, that concluded that the most cost-effective solution was an operational lease. But as Jim may elaborate in a second, it's not always possible. We may wish to put a primary care centre in a particular location, and we may wish to do that through an operational lease model. But actually, if we can't attract interest locally, we can't identify a site locally, then that becomes problematic to do that. So certainly that's what that concluded. It is our intention next year, informed by the deeper guidance, to do what's now called a cost evaluation exercise to explore again the three different modes of delivery to see which in today's circumstances is the most appropriate model, and we'll look at that, of course. But I think the models that we have on the ground now reflect the fact that there's no one right solution. Each, as I say, has strengths and weaknesses, but maybe Jim would add any light and shade around that.
Yeah, and just as our focus in terms of our capital plan has been on the higher priorities where we have no interest from commercial entities to develop primary care, and also in terms of focus on developing our own facilities, extending existing health centres to provide the digital combination for primary care, or upgrading or remodelling some of our existing facilities. For instance, some of the old mental health institutions, hospitals, we've kind of developed primary care. For instance, Monaghan would be one where we're developing it in St Davnis. We hope to do something similar in Portlaoise. We have done, we say Loughrea, which is an old community nursing unit. We've enhanced that to provide primary care there. We've extended, we've provided new primary care centres like Vinci Core and Ballyfermot from our capital plan. We will be delivering likes of Finglas and Rowla in terms of the capital plan as well. So, but operational lease, where we get the benefit of the commercial interest in providing primary care, but also they have the capacity in terms of leveraging off the primary care centre for other commercial development associated with health, like the pharmacies, other private consultancy suites that come into those developments, which all enhance the delivery of the primary care.
Can I ask GPs that would be interested? There seems to be a reluctance of some GPs to get involved throughout the country. what kind of grant aid is there for a GP to set up, get the full primary care services in place? Is it grant aided to a percentage, or what way does it work to get people interested and get people, even business people, getting involved in a PPP?
Well, there's no grant aid for GPs or for anyone else involved in primary care. And actually,
there's no grant aid at all for setting up a primary care. No,
actually, there was a report done. Probably I forget down the year of it, but there was a report commissioned by the department in terms of looking at the incentives to enhance primary care, and didn't come up with that grant aid or tax measures would be the way to go. That was done probably 2013, 2014. It wasn't. It accepted that the models that we had in place should be sufficient in order to develop primary care. I mean, in relation to GPs themselves, if they have maybe invested in their own facilities and they're reluctant, obviously, that they've already carried out the investment, don't see any reason why they have to move into a new facility and maybe abandon what they have already developed. They may have mortgages, leases already incurred, so they don't have the freedom to kind of go into new locations. In relation to our own facilities, we do offer GPs a licence in the rooms at a very attractive rate to operate from our primary care centres. We're worried about them ourselves.
And the target areas, population areas, is that the target population areas? We say small village of a couple of hundreds, you wouldn't have a primary care. Or do you look at bigger towns, populations? Do you target certain areas? What's the criteria to have a primary care rolled out in a certain area? What's the criteria population-wise?
There's been a mapping exercise done on primary care, so all the countries covered by primary care. We had that prioritisation exercise, which was referred to earlier in 2012, in relation where we identified where to prioritise them in the context of the service requirements, the accommodation available, and the deprivation index, which gives a priority. So we were looking at that as our initial in terms of priorities for delivering primary care. And you can see in that priorities to do focus on areas of deprivation where we have very poor facilities ourselves, where we had growing populations, where we didn't have any existing facilities in order to deliver primary care to around the cities and the towns. I think what was referred to earlier in terms of the recommendation report is probably timely to review that priority list now and see whether we should be refocus our efforts.
And naturally, if there's PPPs involved, people are there to make money, business people are there to make money. So do you have a problem where they all target certain areas where there could be too many primary care facilities in, like a Kilkenny city, and maybe none out in smaller towns around where it's needed as well, that the footfall they be looked at and the profitability of the project. But can that happen, that you have too many offers in one area and nothing in another area?
Well, when we advertise, we do actually get an expression of interest. In most instances, in most areas, we advertise for location, so it's not. This isn't operational lease, so it's not a.
Do you give a license or lease?
It's an operational lease where there's a 25-year lease. We would take a 25-year lease on the premises. The PPPs is a separate.
So the HSE can dictate where these are placed?
Yeah, absolutely. We take the locations, we advertise locations, so we're not saying we're going to one location because there's rather than where we require the centre.
Right, before I leave this, I was asked by a colleague of mine last night to ask about primary care centre in Clondalk, and I don't can ask individually, but in Rolla, is that planning permission is being given and it's 6 years in the making and everything, but there's no progress. Can I ask about an individual one? Is that allowable?
I can answer that one. I mean, Carlow is one of the high priority locations. We have been struggling to get a site there. We did come into an agreement with the C Dublin Educational Training Board in relation to a site there. We're beside the community school there. We're in discussions with the Department of Education in relation to the transfer of that site. We did get permission to apply for planning permission. Now we're waiting for a licence to commence the building.
So it's in there.
And it is in our capital programme.
And it's one of them ALA ones that are coming on stream.
Well, we'd hope to be subject to getting the licence from the Department of Education to commence building. We'll be commencing building early in 2020 on it.
Okay, I just want to, you spoke about home supports, Mr. Reid. I just want to ask you about, it's a problem we all have about hours home care. And again, it's a help to keep people at home and keep people in place. It's obvious that there's not enough funding there to facilitate what the demand is there. Can you see more personnel and more money being made available to keep people at home as long as they can in the houses from the home support, the framework that we have? There's a big demand on it. people only get maybe a half hour when they should be getting maybe 2 or 3 hours. People not getting any, or they have to wait for 3 and 4 months before they can even get access to some help. Can I just get a comment on that one off you before I finish?
Yeah, sure, Chair. Deputy, thanks for that. I might just ask my colleague Anna Connor to make a comment too, but just say the supports from Home Help are very significant for us in terms of demands, the demographics that we're facing as a country. The funding that we have this year, as you'll see, we've set out the number of people that we'll support. We have sought extra funding as part of our winter plan from government, so very positively this year. We've got extra funding, not in December, we got it back in October, which has been invested already, so there'll be enhanced home care supports being put in up to Christmas and during the winter. In our service plan for next year, excuse me, as you has to be shortly agreed, but you've heard it publicly announced in the government budgeting process that there's an extra 1 million home help hours being deployed into the community settings. So I think they're very welcome, and our total winter funding of €26 million is very significant. Last year that was €10 million in total, and a significant portion of that is being put into home help and indeed nursing home support schemes and delayed transfer of care beds.
And your opinion is that we're getting good value for money from home care. You know, even though there is more money, I accept that as grateful and as thankful for getting more money, more home care hours as well, and the million that's got in there. But it's still not fulfilling the demand that's out there. What kind of demand would you want to fulfil and keep people out of hospital, and keep people out of trolleys, and keep people out of beds and hoarding up beds in hospitals? Would you agree to the way forward, more funding at home care?
Absolutely. Any extra funding we get in terms of home care supports is excellent value for money. If you compare it with the contrasting cost of a patient being delayed in an acute setting or indeed in a bed, it's much more cost effective. A couple of things just specifically in terms of your question. There's a number of aspects in terms of the supply and demand. On the demand side, as I said in my statement, we've over 7,000 people, which is a combination of people looking for new hours and extended hours throughout the day. So more funding next year's budget will be very supportive of that. We also do have in some areas a supply factor in terms of home help providers and care providers, which is a significant challenge in some parts of the countries. As you know, we have a mix between direct labour and indirect labour across the country for historical legacy reasons, but that's where the supply is. So we have a bit of supply of home care hours and help where we want to get more. And we've a bit on the demand side in terms of the extra provision required, but very positively next year's budget will reflect a significant extra.
And that brings me on my last question then, because I was approached by people that work with for the HSE employed in home care, providing home care, and agencies, and there seems to be a bit of conflict, at least in my area, about the HSE employing agencies instead of employing people directly. What's your opinion on that? Why do they have agencies and there are people available that could do the work employed by yourselves? They're not getting full hours, and yet they're bringing agencies, agency nurses in to do it instead, and there's a bit of a conflict over that, that the priority should be given to the HSE workers. Yeah, I'm not going into relationships, labour relationships or anything like that. But
no, it's primarily where we have the difference between direct provision hours of HSE employees and let's say contracted hours by profit or not-for-profit companies is largely a function of history where the supply has been. There has been extra cost pressures on us this year by wage inflation and workplace relations agreements, so the cost per hour has gone up. But
specifically, the agencies are costing more than direct employment. Is that true?
No, I don't believe so. In terms of the home help, we have I think we submitted in one of our breakdowns the cost both between direct provision and indirect provision. You go.
Yeah, so the home support deputy that was tendered there in the last year or so, and I guess from our perspective the best mix is to have a blended solution. So we have two areas in the country where we have no direct provision of home support. They're all provided by external providers, and that presents some challenges. What we find is that it can be very difficult to source carers in very rural areas at the moment. And we work closely, so when there's a blend of HSE directly provided services and agencies, we can work very closely together. but it is challenging in terms of being able to secure carers all over the country. I think in terms of the costs that you referenced, we had the tender which went up, so in terms of travel time and paying for travel, that impacted on our own employees, but also some of the charges coming in from external providers went up in the same way slightly. So it actually, our preferred way of working would be to have availability of both.
Okay.